Right, so we'll go ahead and get started. So once again, for some of you all who have just popped on, good afternoon. Thank you so much for joining us today. My name is Brittany Armentrout. I'm the Director of Business Development here at the Barry Robinson Center, and we are especially excited to host this informational interview today with our CEO, Rob McCartney. For those of you who are unfamiliar, our residential treatment center services children and teens from military connected families, and it's been our privilege to serve families from all of the 40 states and several other countries. We do hope that this interview today will answer any and all questions you may have regarding not only residential treatment itself, but also how or when to determine if residential is the appropriate level of care for an individual. We'll also explore questions you may want to ask throughout the process to find the right fit. But before we kick off, I'd like to give you a little bit of background about Rob. As the son of a CPA and a professor of nursing, Rob said he was destined to become a social worker. He began his journey of helping young people while in college, working at a juvenile detention facility. After several years of what his mother referred to as wanderlust, he returned to Michigan State to earn his master's degree in social work. Rob's first half of his career was clinically focused, working in a variety of settings, including foster care, residential, hospitals, and outpatient, serving clients ages 5 to 85. The second half of his career, Rob has focused on clinical and operational leadership. He has served as a clinical supervisor, executive director, regional director of operations, chief operations officer, and chief executive director. The Barry Robinson Center has been fortunate enough to have Rob's leadership since 2013. Today, Kathryn Barrett, Emmy-award winning medical journalist and former medical reporter with WVEC TV in Norfolk, will discuss with Rob all considerations for recommending the right facility for your clients. Should you have any questions throughout the interview, you can drop them in the chat box. I'll monitor that throughout, and I will politely interrupt and share with Kathryn and Rob throughout. We'd like for this to be an interactive event, so please don't hesitate to share your questions, your input. Feel free to speak up at any time. So without further ado, I'd like to thank you once again for joining us today, and I will go ahead and hand things over to Rob and Kathryn.
Well, thank you so much, Brittany, and welcome to you all. Thank you so much for being here. Welcome to what's going to prove to be one of the most helpful discussions I think you'll likely ever have about what you need to know to recommend a residential treatment center to your clients. Now, we are calling this style of webinar informational yet informal. Rob and I are going to present conversational style. And meanwhile, Rob will take your questions too, so just write them in chat and Brittany will take it from there. I want to acknowledge what a gem Barry Robinson Center is to our region. It has such a long history, and it's a pleasure to be involved in this discussion of really utmost importance about, the children who need your help the most. I want to emphasize something Brittany said about Rob. Not only does he come at this topic from a residential treatment leadership point of view, but he also brings his clinical experience. And Rob, I want to just start by welcoming you, Rob McCartney, and also to ask you to tell us briefly about those two hats you've worn and what unique perspective that brings to us today.
Well, thanks, Kathryn, and thanks, Brittany, and thanks to everybody who's listening to this. It's humbling to think that people would take the time out of their lunchtime to join us. And I really encourage people to ask their questions. I was working on another presentation yesterday and realized what I was doing with those folks was telling my story. And this is part of that story. And so I don't profess to have 100% of the right answers. I've been doing this a long time, so I think I have some good answers and maybe even some better questions to ask for what residential programming could look like in the next 10 years. When I was in college and working with kids, I never really thought of becoming a social worker. And I think Brittany said it right. My mom called it wanderlust. I traveled the country after undergraduate trying to figure out what to do. And I stumbled on to becoming a social worker and realized I loved the clinical work. I loved being a therapist. I loved working with kids in residential. I was exposed to a lot of structural and strategic family work early on. I was a certified DBT therapist at one point in my life, if those folks know what that is, and was moving forward with my clinical work, and had remarried and had two girls the same age as my two boys. And one day I was talking to my wife, Shirley, and I said, you know, we're going to have 4 kids in college at the same time. And my wife, like a good Southern woman, said, what are you going to do about it? And, you know, as a teacher and a social worker, right? So I went into administration, and I've been extremely blessed that I've had some opportunities for a lot of successes. Stubbed my toes a few times, but as we know, those are great learning experiences. And I think what it brought forward is that when I start thinking of my operations and clinical programming, I put first, you know, what can be done clinically to help the individual out, be it a senior citizen in a geriatric program that I ran, in an acute setting where you're only going to have kids or adults for maybe a week at the max, to long-term residential as well as to foster care. Sort of start with the end, and then figure out what we can do to develop programming to get there.
All right, let's dive right in on a question that some people might be surprised that we're just going to get to right away, Rob. And that is, why are some clinicians reluctant to refer a child or a teenager to residential treatment?
I think that's a great question. I think the biggest answer to that, at least as a clinician, is sending a child to residential treatment or even recommending it is a huge issue. You're talking about the child leaving home. You're talking about the disruption of the family system. You're talking about the kid going someplace that may or may not get the care the parents would like. There's a lot of stuff that's in the press about the negative impact of residential care. The really good stuff doesn't get a lot of press. But as a clinician, the family has come to you and put their trust in you. So as a clinician, you're being asked to make a recommendation. And that's a big thing to do, is to be able to support the family and reassure them that you know what you're talking about. So they can make a decision, we're going to send our child to this residential program based on the clinician's recommendation. And if things don't go well, then it's that clinician's reputation as well as that relationship with the parents that can be hurt. So I think that's part of it. And then I think the other piece is a really lack of knowledge of what are the residential programs out there. What's the difference between an outward bound type of program? What's the difference between a therapeutic boarding school and residential treatment? What's the difference in residential treatment today, where lengths of stays are anywhere from 90 to 150 days than, 10 years ago when kids were gone for 2 years? Understanding what to expect in residential treatment programming. So I think it's both the fact of two things: being able to support the family and being able to hold that trust that they have in you, and at the same time then getting more information about a residential treatment program.
So a lot of it might be perception. Does it also mean, and no offense to anybody, but does it mean that what you have tried so far hasn't worked?
Yeah, I think so. And when you look as far as residential and or even kids who come to residential program, I think understanding the journey when parents come and kids come to residential treatment center, they've gone through probably outpatient work, medication adjustments management, probably partial hospitalization, 2 or 3 acute psychiatric hospitalizations, and those have not worked. So this child, by definition, has been a treatment failure. Right. And so parents are coming in with that real sense of failure and looking for hope. And I think that's one of the things that a strong residential program can do, is to start to give parents that sense of hope. And when parents feel hopeful, kids start to feel hopeful, and you start to see improvement.
Well, clearly, if you, the therapist, are thinking about recommending residential treatment, you're taking that therapy to a new level. So is there a certain threshold, certain behaviors? Of course, I mean, every child's different, but are there certain thresholds to cause you to say, okay, we've reached this point now?
I think you made a good point. Every case is different. And I think you have to look at the age of the child. And while we work with kids 6 and above, those are the ones that you hate to pull from home at that time. But when they come to residential program, they're pretty acute. So when you ask about the thresholds, you're looking at kids who've probably been self-injurious, and that could be cutting behavior, it could be suicidal attempts, and keeping them at home may put themselves or the family at risk. So they are in need of a more secure, structured setting to ensure their safety and the safety of others. For those of us who are trained psychodynamically, often you have to supply the external control and sort of supply the structure to contain the child's id. So we're being sort of the super ego in residential to provide that. But that's a whole different story about my clinical training decades ago.
Well, therapy is focused obviously on the child, but you mentioned, family dynamics, but obviously therapy is not just about the child. The whole family is involved, right?
Right.
So I am sure a lot of the people who've joined us today on this webinar know a lot about family dynamics, but I just thought I'd ask for my own edification of what sort of emotions are those parents going through? And how do you as therapists deal with that? Jumping from the clinical setting they're used to talking about the residential treatment center.
Well, I think that with parents, we could do a whole nother talk about family system and structural family therapy. And those who are listening, I refer you guys to a guy named Scott Sells and his FST model of structural and strategic therapy. About nothing happens in a vacuum, and you can hypothesize that a child's behavior may be symbolic of what's going on within the family system. And so there's the child's behavior and the teenage behavior has been resistant to traditional therapy or the current family therapy. So everybody's going to be frustrated and they're going to be angry. And if you look at our kids, so many of them come from divorces and from blended families. So often you have multiple families involved in this, where there's that ongoing conflict between parents for trying to figure out how to co-parent with each other, especially in times of crisis, and especially when there may be geographical distances on that. So parents are going to be frustrated. They're going to be short-tempered, I think, a little bit. They're going to be tired of the system. They've invested a lot of time and energy, and nobody's had the ability to fix the problem or to make it a little bit better. So there's a certain level of skepticism as well, and a certain level of distrust, maybe too strong of the word, but there's a lot of need to develop that trust with parents.
Well, what is the clinician's role in helping the parents gain a little more trust? I mean, they have a special bond that they have created for, I don't know, however long they've known each other. So how does the clinician help that family begin the process of searching for a residential treatment center?
I think one is the clinician themselves become educated, that they can talk about a program, or to be honest and say, I don't know anything about this program, but here's what I've heard. Here's what the Google reviews have said about this program. Here's what some other social media may have said about the program. So the therapists can do their own research as well and be familiar with what residential programs may be out there that can be helpful. I think also for the clinician to know what's going on at the residential program from a treatment standpoint. What's their treatment model? What's their philosophy? What is the whole thing about, their milieu therapy? Do they have programs like Boy Scouts or choir? What's their school setup looking like?
Right.
Certainly you wouldn't expect for the individual therapist in the community, right, to know all of those about all the residential programs, because residential treatment, right, is not something that happens every day. So what an outpatient therapist may only have one, maybe two kids that may need that level of care. So they need to be able to have a place where they can go to ask questions.
So is it up to what's the ratio of the parent's responsibility for finding a residential treatment center and the clinician's responsibility?
Yeah, well, I tell parents there's nobody's going to be a better advocate for your child than you are. There's not going to be anybody who's not going to know your child better than you. You've walked this path with them, and while it may be very stressful right now, and you may be frustrated right now, you're the one who's going to have to take responsibility for this. And as parents, they're the ones who are going to take the ownership if they decide to admit their child or get their child to go to residential care. So if I was looking at a balance percentage-wise, I'd say 80% parental responsibility and 20% of the therapist's responsibility. A therapist may recommend to me that my child need residential treatment. And then at that point, okay, I'm going to do my own investigation. And I'm going to look at programs and maybe, I said, go on social media, talk to people to find out more.
Okay.
And then I may take it back to my therapist and said, I found out this program, what do you know about them? Could you make a few phone calls and validate that for me?
Okay, let's move right now, since you brought it up, of what to look for in a residential treatment center. Now we're going to get into the nitty gritty about staff, child ratios, and those types of things in just a second. But what is the overarching characteristic that people should look for?
Sure. Yeah, when I've been asked that question before,
Oh, you mean I wasn't the first one to ever think of that one, huh?
Close. The way you worded it, you were the first one.
All right.
What do you look for in a residential treatment center, right? And I think it has to do with openness and transparency. Are they going to answer your questions? So you call up and say, I'm looking to my child to go to your program. Will they talk to you about that? If you send an inquiry out about that, how quickly are they getting back with you? One of the things that I've done in the programs I've worked at is tell parents, the best way to find out we were talking about this earlier, the best way to find out what's going on in a center is go visit. And then, how are you received for that? Do they take you on a tour? Do they get a walk around campus? Every program can do things a little bit differently, but it's more of just the transparency.
It kind of, a little off topic here, but it kind of reminds me a little bit generally about looking for colleges. All the buildings after a while start looking the same, and the websites all look kind of the same, that you need to get in there somehow and figure out what is the difference. And then in this case, what is the right center for the right child? Because from what we have talked about leading up to this webinar today, there are a lot of different types of residential, not types, but residential treatment centers don't do everything. They
Correct.
all don't do everything.
Well, I think that looking at colleges go ahead, Brittany.
We have one question that has come through. I'm trying to find the right way to politely interject. We have one question, and that is, what is the best course of action, or how do you guide parents and a teen when they are old enough that they have to sign themselves in, but they don't want to?
Good question.
Well, there's a couple things that's a good question, Brittany. And I think there's a couple things that help. When you look at the family and the teen know that treatment hasn't worked. And often a child's resistance can sort of parallel a parent's ambivalence. And so especially if there's a separation and there's some conflict in there. But for the child themselves to say, yes, I'll sign myself in, what we found to be very helpful is that we've done Zoom interviews with them. We have taken them sort of on a Zoom tour. They've gotten to meet some of our staff face to face. They've been able to talk to our psychiatrists before they've come. And I think that for children, for the teen, is that they're scared. And I think understanding that while they may be aggressive, they may be tearful, they may be say, I'm never going to sign myself in. I think if you go at it from the fact that that's due to their anxiety and to their fear, and help them address that, right? You think if you're going to go to a hospital to have a procedure done, often it's good to go to the hospital first. Often they will come up, they'll walk you through the procedure. Once you're in there, it's going to go on. It's about knowledge. But that's a great question. And the challenge can be too, is that often then if you're looking at our state in Virginia, you know, teens have to sign themselves in at age 14.
That was my question. Are we talking about 18-year-olds? But you just answered it. Really? 14?
14 years old. Yeah.
The therapists I'm seeing people shaking their heads saying, yep. And I'm wondering how many people have run into the issue of 14-year-olds saying absolutely not, rebelling. I mean, isn't that what teenagers do?
They do. Having raised 4 of them, and at one time I was one of those kids myself, I go back to the fact that it's developing of the, look, there are going to be some kids who are going to always resist going to residential. And then we start to look at the difference between, is this a mental health issue? Is it a juvenile justice issue? Is it somewhere in between? Is it a conduct disorder issue versus a mood disorder issue, or a executive functioning issue that's going on for children? Most kids who are there, though, have gone through a rough time themselves. They do not like where their life is. And if it's just simply the fact that the child is a conduct disorder or showing opposition or defiant disorder, they may not agree to come into a program that requires them to sign themselves in.
So what are some things that you would talk to this teenager and the family once they arrive and look around for a tour or on the Zoom chat?
Well, I think the first thing is you have them walk around and with somebody who will be engage with them and answer the questions. Pre-COVID, right? Now we have some other restrictions. You know, let them go in and see the dorms. Let them go in and see the school. Let them go in, you go back to college, right? When you drop your kid off to college, where do you want to see? You want to see where they're going to lay their head. Let them meet some of the staff. Let them ask questions to the direct care staff. Let them go into the cafeteria. Just get that sense of the flavor for that tour.
And
Have
how
another
long?
question that has come through.
Sure.
Google reviews can be a tricky situation, similar to Yelp and other avenues. More people tend to post negative reviews than positive. How do you reassure a parent that a facility is, in fact, a safe and therapeutic model and not representative of one negative review?
Well, as you know, Brittany, we've had those negative reviews ourselves. And I think that being proactive, right? I think that they're absolutely right. A person who's had a negative experience with anything is more willing to post a review. I think that as an organization, and we're looking at ways to let folks know what we do well, is that when you've had a family that's had a really good experience, I think it's good to ask them if they'd be willing to post a review. You know, obviously you don't push it real hard. You simply ask them for that. They may not know, they may not have thought about that. So I think that's important. I think the other thing you can do is that while you can get testimonies from parents and you can write them down, it's also possible to put a book together. So people may not go to Google reviews, but they can read the positive comments that other people have shared. And there's different social media places on that too. What obviously as a parent, I wouldn't want to see if all I saw Google reviews was just all negative and looking at the negative score on that. But I agree with them. Social media can be misleading in both ways. So that's why you go back and ask, go for a tour and get a sense yourself of what it feels like.
What are your recommendations for things I mentioned that we talk about, like staff to child ratio and other services on campus?
You know, it's always so much of what we do in this field based on is regulated by state regulations. You know, when I worked in North Carolina, we had a requirement that we had a 2-to-6 ratio of direct care staff to children. And so you may say that's 1 to 3, but that's not what the reg was. The reg was 2 to 6. So any group of 6, you had to have 2 staff. So if you had 1 person, 2 kids, you still had to have 2 staff. When you went to 7, you had to have 4 staff. They recently changed it, some of the rules on that. So much of what we do, we follow the state regulations. And the whole issue of what is healthy and safe, it becomes not what we're assessing, but what the state is assessing. And sometimes you can have too many people. Years ago, my brother, who's literally this genius mathematics person, put together this formula, is that when you went from 2 to 6 to 4 to 12 kids, the number of potential communication interactions went from something like 215 to almost 10,000. And so you have, again, if you think of just the mere communication opportunities and miscommunication, it becomes more stressful. And when does having more staff then take away the responsibility of the staff and they say it was somebody else's job? That all being said, what I have found, right, with the staff is that a 1 to 3 or 1 to 4 ratio seems to work well. It allows for one-on-one work with the kid. And this is especially in the second shift or on weekends. During the school day, you have a lot of staff. You have teachers around, cooks around, maintenance around. So you have, and administration folks. So you have people there who can help out. But in the evenings, it allows for staff to do some one-on-one work. It allows the staff, if a child needs to take a break or get away from everybody, to do that with a staff member. It allows a staff member to get on the phone with a parent. So again, you look at sort of that 1 to 3, 1 to 4. It allows, if the team leader at that point feels uncomfortable or unsafe with a child, they can maybe do a 1-to-1 with a child. So it can vary with that, but that's sort of what I have found: 1 to 4, 1 to 3, 1 to 4, and depending on the level of acuity, you can probably get to 1 to 5.
Is everything focused on behavioral treatment once you're in residential treatment, in a residential treatment center? Or are there shades of normal life as well?
Well, I think that the one way to ask it is that we have our traditional therapies, and then you have the therapeutic milieu.
Yeah, that sounds better than the way I put it.
Yeah, right? Well, it's like it took me only 5 years to be able to pronounce that word. And but when you cross the threshold into a residential treatment, everything should be based toward some type of therapeutic message, all the way from the greetings and engagement to your wall hangings, to your painting, to your flow. It's like being in a hospital. You're going to want everything in the hospital is talking about health and talking about what that hospital can do. And the message, it needs to be, we're here to help you out. So we have the traditional therapies where somebody may have individual therapy, group therapy, which is something we could talk about later too, how that sort of is, I don't think is the best way to go these days. We have family therapy, we have medication management, we have nutritional therapy, right, with nutritionists, but then you have rec therapy. But you also have other programs like you have music. And while music can be music therapy, just the process of going to a music class, learning how to play a new instrument can be therapeutic. They have art therapists, but not all artwork is, quote, therapy, but artwork in and of itself can be very therapeutic. Exercise, while you can work with an exercise physiologist and a rec therapist on certain things that can help with grounding, especially with kids who are traumatized. But the mere act of exercising, we know, has a positive impact on us. So you start to look at, the schedule that the child is in. School is not necessarily therapeutic, even though that's where a lot of problems for kids occur. But the school process can be a healing process and therapeutic as well.
What about outside things like programs like Boy Scouts or these kind of, I wouldn't call them therapies, I would just call them, I don't know, real life stuff.
Yeah.
Yeah.
So yeah, I think that's right. We've been fortunate. We've had a guy with us for years who runs our Scout program.
Oh,
And what you find out with scouts, right, there's a lot of opportunity to learn leadership skills, working with each other. A lot of things folks of us understand as clinicians that will help with self-esteem and a sense of internal control, and as well as it helps to develop more executive functioning. So learning how to tie a knot successfully, learning how to maybe set a tin up with a partner, learning uh, about flags and about, how to retire a flag and the process of doing that. Wearing your scout uniform. At our prayer services, our scouts, up until pre-COVID, would present the colors and lead us in the Pledge of Allegiance. Being part of that group can be helpful with that. We see the same. On Monday, we start a running program for the boys. And so we know we're going to have the physical exercise, but it's also the group process and the group goals that they'll be looking at.
how much, so what I hear you saying is that there are some like outside real life experiences that children should, or that parents and therapists should look for in a residential treatment center, in addition to all the behavioral modalities.
I think that can be helpful. And again, depending on the severity of the child and the need for a secure environment, that may change. But one of the things our kids do is they do they do some volunteer work. That includes going to to places that distribute food and raising money. They've done car washes for people who've been homeless. They've done car washes for an abuse shelter. So the idea of giving back to others can be very therapeutic in its process. And so our kids participate in that. And then receiving a thank you note from an organization for your kind donation. When I've gotten those as the CEO and had the opportunity to go over to the classroom and read them to the kids that were involved, their smile and their pride is observable.
Let's take a minute and talk for a little bit about how residential treatment centers keep up with a child's education, or should they keep up with a child's education?
Well, again, depending on the state, you're going to have different rules and different requirements. In the state of Virginia, we're required to have a full school. And depending on how you identify hours in the chair, you're going to have school that's going to be anywhere from 4 to 5 hours a day. So the reality is our kids are going to be in school. So the question then comes is, what do we do to help that both through their education, and how do we make that therapeutic, right? So some programs will have kids that will come in with IEPs, even though residential programs, again, in Virginia, don't do IEPs. They may bring with them a 504, and parents will be expecting your agency to maybe follow the 504 or follow the IEP, though that's not what a residential program is mandated to do. I think the challenge often is that so many of the problems that children experience get manifested in the classroom or manifested in academic progression, that becomes the focus. And we tell parents, while education's important and we're going to address it, we need to address why they've come to us first. And most kids have not come to us because of failure in school, though that may be what's going on. They've come because of self-injurious behavior, emotional dysregulation, some out of control issues. But again, you go back, and with parents, school can be very important as well as the child. So a couple of things you can do with education. Certainly you can leverage the internet. We have 2 online educational platforms that we have our kids get invested in. We have special education teachers, small classroom size. Our direct care staff also act as school aides. So we have that small ratio. We have a lot of contact with the homeschool. We've actually, with some of our homeschools, we've been able to utilizing the internet and their online program, connect the kids onto their online school. So it becomes difficult because if you have 60 kids in a program, you're going to have basically 60 different educational needs and trying to figure out how you meet those needs and still teach a classroom. Think of a one-room classroom out on the prairie and multiply that by probably about 10. And the fact that they change, your composition of your classroom is going to change every month.
And maybe school is some of the cause of the problem.
Yeah, often. Well, it can be cause of the problem, either that they're being pressured to succeed or that they are feeling like a failure.
All right, let's ask, if no one else has any questions about education, the education component. I think we'd like to know a little bit more about what the family should expect and what the therapist can expect to tell the family about. Should they be involved? Are they allowed to visit? This kind of thing.
Yeah, with the group that we work with, we have a lot of parental involvement. Not every residential program in the cohort group that they're treating has that same experience. But we do know that when children leave us, they are going home to whatever that means, right? And so if we don't make some changes at home and within the family system, the odds of the individual transitioning the gains they made in a residential program go down. Doesn't mean they won't make them. It doesn't mean they won't sustain them, but it goes down. 10 years ago, when we had kids who were with us for 2-3 years, maybe that's a little bit easier. Maybe they've developed the internal changes. Maybe they've become permanent. But when you're talking length of stay of maybe 6 months, the odds of being able to really internalize and make those permanent changes is not going to be that high. They'll learn some skills. They'll be able to settle down, but they're going back to the same environment that their behavior and their events that led to their need for residential are going to occur. So getting the parents involved, or the guardian involved, or foster parents involved, or kinship folks involved becomes critical. It's also critical too, because a strong message, if parents and family are not involved to the child when residential, is we're not going to be involved with you not residential. And I get it. You think about how would that feel, right? Your parents put you in a residential, your guardian signed you in, and then they have nothing to do with you. And they're waiting for you to get fixed when you as the child know this isn't all my fault. So parents got to be involved.
Yeah.
Yeah.
And what should the parents' expectation be? You mentioned, what is the average residential stay these days?
For us at the center, we're at 152 days, and it does break down based on age. With our younger kids, are probably moving closer to that 7-month stage, and our teens are probably closer to that 120 day stay, maybe 130. I think a lot of it has to do with the child's ability to conceptualize problems and their cognitive development and some of their impulse control. That's with parents understanding that their involvement, and I saw the question that they had about being inconsistent with treatment. I think that when parents need to know that we're not asking them for years of investment, what we're asking them for is 6 months worth of investment. We're asking them that maybe once a month, twice a month, they're on campus doing some family work, and then being available via video conferencing to do more work. And I think one of the things that COVID has really opened up for us a lot is the use of telehealth video conferencing for all forms of treatment, including family work.
So you're reading the chat, huh?
I saw the one that came up. It said something about, and maybe Brittany can reread it to me, is what do you do about, so I think it was inconsistency. Was that right, Brittany?
You hit the nail on the head. Thank you. You're helping me out with my job here. The question read, what happens if the parents are inconsistent with participation in treatment?
Oh.
Yeah, so I think all of us who've been working residential we've seen how that can often light the fuse for the child. And so the challenge for any residential program is, how do you decrease that inconsistency? And so I think one of the things you have to ask is, why is the family inconsistent? And as a clinician, if you start to address it as a resistance to treatment, that it's a defense mechanism that I really don't want to change. You start there. Now, that's not always the case, but you start there because that gives you the opportunity to maybe address the issue and help decrease that resistance. I think part of it also at the very front end is talking to the parents and the families about what the expectations are. And most parents and families will shake their head, we're going to be involved, and then they're not involved. And then what do you do at that point? And again, it's going to become in what's the level of what your programming is. And the question to ask is that if we keep this child in residential and the parents are not going to be involved, are we really helping the child? Are we really helping the system? Are we doing more? Are we doing harm with this? Are we sending the message that it's all the child's fault? And that no, the family, the parents don't have to be involved. And those can be really, really tough conversations to have. But I think it goes back to, from each organization, what is going to be their clinical expectations of parents, and if parents are not going to be involved, do they continue to offer the treatment? And if you do, then understanding the parents aren't going to be involved and the opportunity for success may decrease.
Do you find that?
Hey, Kathryn,
Yeah.
You want to read this last question I quickly looked
I
at?
did have one question just come through. What happens if the parent is overly involved and contributes to the child's anxiety and self-harming behaviors?
Being an old family therapist, right? We depended on Murray Bowen, everybody knows who he is, and he talked about undifferentiated ego mass, and he talked about enmeshment. And so you're talking a lot about what happens when families may be a little enmeshed. And in fact, that family can be sometimes even more challenging than families that are distant. And so the family therapist, I think that becomes the issue, is that does the individual therapist also do the family therapy? And again, another discussion we can have at some point about the pluses and minuses to that. But being able to sit back with the parents and understanding why they're involved. What is their own anxiety? What would happen if they were not as involved? And getting the parent to be able to see that their involvement is creating the anxiety. I think that many therapists who are trained individually, or maybe even in groups, don't have that comfort level to really address what's going on in the family system, and to start to think about what strategically and structurally one can do to shift that dynamic. But again, that has to do with a lot of different types of training and what I call true family therapy. And that, for me, that's structural and strategic work. And but if you got a parent that's overly involved, at least you have them there to be able to work on. Often in residential, we see this over-involved parent calling the dorm and getting mad when the dorm workers don't call them back, or when the child calls the mom up and says something about they were just yelled at, or they lost a privilege, and then the kid getting upset and the parent being upset, or the child asking the parent to take them out and the parent then calling somebody like me and complaining.
What are some of the negative impressions, some rightfully so, some myths, negative impressions, thoughts that you have to consistently try to overcome when when families are looking at residential treatment centers?
Sure, you go online and you start to look them up. You see issues of kids dying in restraint. You see kids running away. You see kids being hurt. You see organizations being investigated. You look at their licensing issue, that the issues of control. I mean, I think it's the bigger ones are more of the fact that residential programs are often, we don't have any other choice, but we got to do something with them. We send them there, and they don't see it as a true option for some really good clinical work. I think the biggest challenge residential programs have is overcoming that issue of being hurtful, because again, those are the things that get talked about a lot. Those end up being our regulatory compliance issues, our licensing um, challenges, and not with the fact that a kid came to us who had tried to commit suicide 3 times and was with us, and we were able to help with medication management and adjustment, and left us and is now sending us an email that they're getting ready to go to grad school. I mean, and that kind of stuff is not what, makes the papers. So I think that understanding that, however, and we've had some very, very challenging issues in the press the last couple of years. And that's what folks are going to hear. Now, that being said, as a parent, and I'm worrying about my child's safety, right? Because that's what we're talking about. Is the residential program going to be safe? Both physically safe first, right? And emotionally safe second. We know that the major point of injuries for any residential program come from is restraints. It's the place where children get hurt, and it's the place where staff get hurt. Number one cause for workman's comp is a restraint. So anything that a residential program can do to decrease restraints will help them in the long run, both with their workman's comp experience and as well as with their PR. And that's probably one of the most difficult things to do. But if I'm a parent and I'm looking at a program, I'm going to be asking them about restraints. I'm going to be asking them about their therapeutic milieu program. I'm going to ask them about what they do for debriefings with restraints. You're going to call me about restraints. What do you call a restraint, right? Historically, we used to have, quote, therapeutic holds, or we were just escorting the individual. Well, by definition, those are all restraints. Anytime you restrict an individual's movement with that or put hands on. And so what is the program doing, not just to decrease restraints, but what are they doing to even avoid that event that led to a child needing that level of intervention? And you only put hands on them when a child's not safe to themselves or somebody else. So I'd be asking about those programs with that, if I was looking at program as a parent.
What if, in this day and age and of everyone looking for revenue streams, you might think that any residential treatment center would take any family just for that revenue. However, when is it appropriate to say, this isn't the right place for your child? Yeah,
Kathryn, I think you bring up a great question that can be extremely sensitive. And right, because at the end of the day, well, when you look at programming, right, we don't stay in business if we don't have enough revenue, right? We can have great treatments, and if people aren't willing to pay us for it, we're going to be out of business. So as a business, right, you have to know where that revenue is going to come from. And anytime you have an empty bed, you're going to be losing some revenue. And so you have to be acutely aware of what that will look like. So that being said, there's another old statement is that I'd rather have an empty bed than wish I had an empty bed. And by that, I mean, you may bring a child in because of concern about having a person in the bed, and that child may not fit your treatment program. And if that's the case, then that child is going to have more issues, and it's going to take up more staff time. And you're going to sit there and going, nah, maybe we shouldn't have admitted that child. And right, and it may not be anything to do with anybody except for it's a bad fit. I also think that when you treat everything as an organization, we take everybody, we can manage everybody, then maybe you can. I have not run a program yet where I felt that we did great with everybody. A good example is we don't take eating disorders, diagnose eating disorders. We work with young ladies and young men. We have eating disorders on campus. That's just part of the nature, but we don't put ourselves out there as an eating disorder program because that's a very specialized treatment. So if somebody referred to us that and we saw that, we wouldn't take it. We also are not the place that does the first place to go to if you're looking at both comorbid medical issue and mental health issue. Even though we have some kids who may have brittle diabetes, but it's under control and they're not using their insulin as self-injurious behavior. That's not something that we would look at taking. So we don't take kids for us who are sex offenders, right? Or who are sexual perpetrators. That's a whole different treatment model and a treatment approach. Don't get me wrong, we have kids who have sexual issues and may have had some perpetrating behavior, but it's not their primary diagnosis. And when we've seen that, we've gotten testing done on that. And with those kids who we find we should not have brought in because we don't treat them clinically, we have really good partners that we refer to that we know do a better job. So if you think about what you think of what's in the best interest of the child, you know, you have to ask the question, are we the best place for this child to get the treatment they need? Or is there another program we know about that does a better job treating us?
Right. So if the answer is no, this is not the best treatment for this particular child, the fit isn't right, is there a responsibility at that point for that treatment center to offer assistance?
I think the fact that, well, I think that when you talk about responsibility, I think there's, I think it makes sense that if you were to call and say, Rob, I have a referral for you, and I say, and you're a parent, right? And you're a parent that's reached out to me and to my program, to somebody like Brittany, and we know we can't help them at our center. This parent is looking for help. And so part of what we do, right? We're not just in the business of residential work, we're in the business of helping people. And so, and we know the system probably better than the parent does. So we try to help that parent find a program that's a better fit. And my team pretty much stays with the parent unless they say, don't bother with this, I've got it, with them until we can get them referred to another placement.
This might be a little bit off the topic, but you did touch on it a little bit earlier. And it's not on the topic of how to choose a residential treatment center, but how do you know that you've chosen the right place? What behavioral thresholds would the child reach upon leaving the residential treatment center? Obviously, there's no, 152-day quick fix.
Right.
But how do you determine success, I guess, is my question.
Well, I think part of that has to do with each child, as we know, those of us who have been a long time, has an individualized treatment plan. And that discharge criteria needs to be tied into what that looks like. And early on asking parents, what will it look like for your child to be ready to come home? What will it look like? What target behaviors and symptoms are you looking for, right? So I think it's going to pull the parents in and the family in as far as making that decision when they're ready. I think the other thing is to let folks know is that, there's going to be a lot of work still to do after the child leaves, right? We're not going to fix them. About 20 years ago, I broke my elbow. I had surgery. I could only move my wrist a little bit, right? The surgery lasted all of about 2 hours. My rehab lasted almost a year to get my range of motion back, right? So the same thing with residential. You're here for a certain period of time, but so much of the work has to be done on an outpatient basis. So part of the discharge criteria is what services can be set up outpatient wise. The other piece too, sometimes this becomes a medication management issue. And children, right, need to maybe have what we call a med wash, get them off their meds, let's get to baseline, and then let's slowly get them back up. And they may hit that sweet spot sooner than later to where the child is ready to go, and what can be managed with that. So I think I go back to, you ask, when is a child ready to go? It's going to be based on that treatment plan and what the treatment team, which includes the parents, is comfortable with.
And isn't the treatment team also going to be the therapists who are joining us today? Would the child necessarily go back to the family, the therapist who's been involved for maybe sometimes years with that family?
Kathryn, you bring up a really good point, is that how do you pull in the outside professionals who've been working with this child for several years? And a lot of it, so if I'm a therapist, I'm working with the kid for a while, how much am I going to be involved with this child's treatment? And I would certainly hope that somebody would reach out to me and ask me about my experience with the child. But I can tell you, often the outpatient therapist, when the parents push the kid to residential, is they acknowledge them, they're there, but they don't get that involved. Now, hopefully, if they're going back to that therapist, there's a lot of involvement in pulling that therapist in. But I think that, and also as an outside therapist, how much do I want to be involved? How much time do I have to be involved with each specific case? Again, you look at my internal medicine doc, right? When he sends me in to have work done at the hospital, if I have some surgery done, they're going to want to be aware of what happened, but they may not see me in the hospital. They're not the ones going to be doing the procedure, but my follow-up is going to be them, and they're going to have my records to look at.
I think you give the therapists joining us today a lot of reason for hope, but yet it's the child and the family that you're giving hope to in the long run. And I want to thank you for spending your time and sharing some of your experience. And we've had some involvement from some top-notch therapists in our region and around the country, I see. And I want to thank you for joining us. And Rob, you are one of the leading child advocates in our country, particularly when it comes to the military-connected child. And I just want to thank you for what you do, the time you've given us, the hope you give to so many families. And it's been a pleasure being part of this conversation. Now let's turn it back over to Brittany.
Thank you both so much. A big thank you to you, Kathryn, as well. If there's no further questions from anyone, again, I would like to thank each of you for joining us today. We hope this was an informational webinar to everyone who attended, but please do know that moving forward, I myself and our reps and really all of us here at the Barry Robinson Center are here as a resource for you all at any time. So that being said, I hope you all have a great week and take care and be well.